So let's get going. I want to just start by talking about the magnitude of the problem. I do have some disclosures. One of them is this, which I have to actually put every time I give a talk, that I'm not going to give away any board examination questions today. So this is not a board review course. If you came to officially. Okay, historical perspective. So survival into adulthood has now become the norm for most types of congenital heart disease. Hence, the population, at least in the United States and developed countries, is growing by about 5% per year. And now there are more adults than children with congenital heart disease. So really a growing problem, a growth industry, which is why I have a job and why you're all here. Much of the credit for the success of this field really goes to the early surgical pioneers. We should give credit where credit is due. Blaylock, Crawford, Gross, pioneers starting in the 1940s and then into the 50s with advances in cardiopulmonary bypass, allowing them to now operate within the heart, not just in the extracardiac vascular circulation. And that really catapulted cardiac surgery to the forefront of medical advancement, and it was a real golden age. And a lot of it started with congenital heart operations, and I think we should keep that in mind. By the turn of this century, cardiac surgery had really become a refined art and the gold standard that we aspire to achieve or get close to when we try to do transcatheter procedures. Here's a visual representation of these changing demographics as far as age of congenital heart disease patients. And really look in 1965, 70% of those patients were children, and now close to 70% are adults. And we expect that will slowly continue to grow as people survive longer and longer. There's about 20,000 new patients per year that are being seen in the United States. Back in 2010, the estimate was that we had about 1.3 million adults. And many of these, at least that are being seen at specialty clinics and centers, are moderate or complex forms of congenital heart disease, not the small secundum ASDs or tiny VSDs, but Fontans, transposition patients, repaired tetralogy patients. And that is actually appropriate because those are the patients that I think we can contribute most to as far as our expertise. It's a big problem as far as the medical system with this rise in hospitalizations. And this is really, Dr. Reardon a little bit later is going to talk about transitional care and the importance of that and not losing these, these patients between pediatric adolescence and adulthood. Because when they show up back in the hospital, in the emergency room, and it's bad for them, and it's bad for the medical system, and it's bad for hospitals. And so therefore, we really would like to promote, and you will see today during this program, the promotion of really good quality outpatient care, multidisciplinary, multi-level outpatient care for these patients. Try to keep them out of the hospital, try to treat them as well as possible in an outpatient setting if we can. Growing problem. So we've already kind of talked about this, but there are issues here. Increased morbidity and more than expected early mortality appear to be significant from data registries. So although we think we've succeeded a lot, there are still major problems. We have a long way to go. Arrhythmias and heart failure are common, as are vascular complications of prior procedures, prior surgeries, or the lack thereof in patients who may have aortopathies. Some of these may be silent until they're catastrophic. They occur more commonly than expected for their age range. Just take arrhythmias, for example. A 30-year-old with repaired moderate or complex congenital heart disease has the arrhythmia spectrum of a 60-year-old who may develop acquired heart disease. So we really are seeing these problems at an earlier age, and they're more prevalent and more difficult to treat. Driving hospitalizations up and really driving cost of care as well. Many patients require complex reoperations for residual defects or worsening valvular disease, and each subsequent surgery does carry a higher risk of postoperative and perioperative complications. We've all been down that road. Sudden cardiac death, a real problem, the majority of which is arrhythmia-related, is well documented in our populations here. We have cyanotic congenital heart disease patients, for example. The estimate is about 10% of them will have sustained ventricular arrhythmias or sudden cardiac death, a real problem, and until recently very difficult to treat before we had subcutaneous ICDs or to prevent or avoid. So what are the long-term complications in adults with congenital heart disease? Well, a lot of the things that I mentioned here, add to that pregnancy, add to that residual shunts, heart failure manifestations. But on top of that, it gets more complex because now we have to add adult comorbidities, coronary disease, peripheral vascular disease, diabetes, obstructive sleep apnea, COPD. Take a Fontan patient who develops obstructive sleep apnea. That can be disastrous for that patient over the long run. So understanding adult comorbidities and how to actually treat these acquired problems is very important. I remember a case about maybe a year and a half ago where we almost went and took a patient to replace his pulmonary valve because he had moderate pulmonary regurgitation, but severe elevations in biventricular filling pressures, terrible obstructive sleep apnea, severely overweight. I mean, really, was the right thing in that patient to replace the pulmonary valve or to treat the obstructive sleep apnea and encourage weight loss and exercise? Well, you know, with those maneuvers, you can avoid some of these more costly procedures. Renal and hepatic insufficiency, big problems in our Fontan patients. Does it matter if you come to a specialty center? So does it actually matter if you are seen at a subspecialty center? Or are we just sort of tooting our own horn, hey, send us patients because, you know, we have a center and we should be taking care of them? Well, it does matter. Ariane Morelli and her group, Ariane is actually a former graduate of the program here who has become a world leader in this field and is in charge of the program at McGill University. But this is data from Quebec showing that those that come to a referral center have a higher likelihood of survival in Canada. Hopefully we can apply that to the United States as well. So, in the United States, how will we deliver and provide access to high quality care? Let's start with the ACHD cardiologist. So what was the past? Past was 1973 is kind of where a lot of this started. And it started with the founder of the program here at UCLA, Joseph Perloff, who passed away now close to 3 years ago. 2.5 years ago, and he was a real visionary, very progressive thinker, and he identified the problem here back in 1973. Pediatric congenital cardiac becomes a post-operative adult, the changing population of congenital heart disease. And he said, and if you read this, despite the present CHD successes, we are obligated to look beyond the present and establish our ultimate goals, asking the question that should define our profession. What are we seeking to accomplish? Our efforts should focus on the quality of long-term survival. Prophetic, really. And even there, he said, multidisciplinary facilities are important for the comprehensive care of adults with congenital heart disease. You don't just need single specialists. And this is highlighted in these guidelines here. Collaboration, expertise, ability to work within a team. Not everybody has to be an ACHD specialist, but you should work with the ACHD team, and the ACHD team's responsibility is to bring in these colleagues and these specialists. Training, let's talk about training here. The training that is dictated by COCAT's requirements is for adult cardiology is very limited. 6 hours of formal lectures is what's required. That's it. So now imagine you're an adult cardiologist, you've graduated, and you're seeing congenital patients in a practice. Do you think you're well trained enough if you've done 6 hours of formal lectures? No. There needs to be more training, obviously. But you'd think pediatrics would be different, that they would have more training. Not really. They say curriculum and certain additional knowledge. I don't even know what that means. I mean, really, what does that mean? How about here? I mean, this is the problem here. You know, we have over 1 million adults. We have only about 4% in specialty care. Why is that? Well, we've got a lack of access to care in much of the country, and then we've got loss of care, and we need to address both of those. We need more specialists. This is back in 2010, or 2011. We've had more since, but we had 63 people trained in the United States. Now we've got more. So we've been pumping them out, like, look at that, entire second row and third row. So, but we need more specialists. This makes me really proud here that adult congenital heart disease is now considered a subspecialty of internal medicine, and you can take a board examination. And this is the board exam from 2016. Kurt Daniels did this, so this is credit to him for putting this slide together. The guy's so busy, I don't know how he has time to do this, but these are all the people that took the board examination and passed it in the United States. And it's about 50-50 from the pediatric side versus the adult side. Future examinations, just so you guys know, every 2 years, 2017, October 2nd, and if you want to register, the window is going to be open on March 7th to May 15th, okay? Go online and see what the criteria are for that. How do you train now for adult congenital heart disease? Well, you've got to do 2 years of training. After you've done either adult cardiology or pediatric cardiology or med peds and either adult or pediatric cardiology. It's a long road, 8 to 9 years, but you know, it's not worth it financially. But from an emotional, intellectual standpoint, it's highly stimulating. Anyway, current ACHD fellowship training programs, not that many. On the West Coast, there's us, Stanford, and our friends up in Seattle. And frankly, with the 2-year fellowship, it may be hard to even fill those spots. So we need applicants. What's the future? Well, planning for specialized centers. How many do we need? Again, data out of Canada from Ariane's group here. Well, if we're going to take care of all complex, new, and part of other ACHD patients, totaling about 50% of ACHD patients in this country, then we're going to need 150 centers, one for every 1.9 million people. So I don't know if we're going to get there. There is an accreditation program that is taking place that you'll hear a lot more about today through the ACHA, and applications are now open. But this program is meant to basically identify quality programs around the country based on certain thresholds. So in order to provide access and deliver great ACHD care, you have to build high-quality ACHD programs. How do you do that? Well, through the accreditation process. It's an aspirational process. It shouldn't threaten people. What it should do is give you the wherewithal, the strength, and the backing to actually go to your centers and get support in order to achieve accreditation. And then we need to train ACHD cardiologists, and that's going to be done through certification, fellowship programs, and the board examination. Thank you so much, and we will go ahead. So if we could hold questions until the end of this session, we'll have the speakers come back up.